Hello and a very good evening to one and all present right in front of your systems. On behalf of the Kidney Warrior Foundation and Biocon, I take great pleasure to welcome each one of you who joined us this evening. Well, today we have with us a special guest. So please, wherever you are this evening, please put your hands together for Dr. Vinu Gopal from the state of Kerala with about 10 years of experience. And today is going to be um, a very different session because we're going to be going more with the audience choice with all the questions you guys are fed in. But however, one of the things that we would like Dr. Vinu Gopal to talk about is something that we've all experienced, we've spoken about a number of times. The last 1.5 year has been very different for each one of us. People on CKD or not on CKD, if you've been a donor, if you've been a dialysis patient, if you've been a transplant patient, or if you've been a caregiver. Well, even if you've been a doctor, life has been very different. So today in this session, we're going to ask Dr. Venugopal first to take us on a journey of what the last 1.5 years in his journey as a doctor has been like, and also take us a little bit on the journey of his patients and give us a little bit of insight globally how things have been looking in the last 1.5 year, and everything will be towards the journey of CKD. So wherever you are this evening, I'm going to request you to please put your hands together for Dr. Vinu Gopal as he takes over the screen. Thank you very much, Doctor, for joining us this evening.
Okay, thank you. Okay, I'm Dr. Vinu Gopal. I'm directly going to my discussion or lecture. And since almost 1.5 years, we are facing this COVID pandemic, and each and everyone in this country, because usually the medical terms will be familiar to only few people. Now the entire country knows what is viral infection, what is vaccination, what is sanitization, what is mask, what is hand washing importance. So over 1.5 years, the entire country has improved the hygienic status at least due to this infection. And actually, it spares nobody. Being a nephrologist, the people we encounter is those with abnormal renal function, like CKD patients, patients on dialysis, patients who are waiting for transplant, or post-transplant patients, immediate transplant patients. These are the category of patients what we deal. And importantly, we have to say that it spares nobody. So over a period of time, you can see that a lot of normal patients with normal renal function, but other comorbidities has reached the stage of CKD. That is, previously their kidney function was normal. Now it has reduced in such a way that they have to be on follow-up, on regular follow-up with medications. And so there is a big shift of normal people to CKD, the CKD people going to dialysis people going for transplant, or transplant patients and dialysis patients dying. This is a common scenario all over the world, and it has been noted that CKD is one of the important risk factors for the mortality, as well as AKI, acute kidney injury, is also as a high. It's a mortality predictor in COVID infection. And if in pre-transplant, what we face is that there will be a donor recipient evaluation, and as a doctor, we will prepare the patient for transplant. Every date will be fixed, and unfortunately, 2 days or 3 days prior to transplant, we used to start the immunosuppressive medications. Then we know that the donor or recipient is positive. Then all of a sudden, everything has to be changed. We have to postpone the surgery for at least a period of 3 weeks. And the guidelines varies from 14 days to 28 days. What we prefer is at least 28 days RT-PCR negativity should be there to take that patient to transplant, because the donor, if it is positive, it can transmit through kidney, it can go to the recipient also. So we don't know, we don't have many data regarding the transmission, etc. So we prefer to wait for at least for a period of 4 weeks before transplant. And the mortality, what we see is commonly in those with immediate post-transplant. That is, when the patient is having maximum immunosuppression. That is, immediately post-transplant, the patient will be having higher number of drugs, higher dose of drugs. And another group is patient who develop these rejection episodes, because we will be bombarding them with the medication, immunosuppressive medication, and they'll be prone for more infections. At that time, just like any other viral infections, the COVID also has taken over the burden on these patients. And actually, we have to say that there is no miraculous cure for this COVID. You have to be case based. There is no definite guidelines how you treat these patients for transplant or CKD or dialysis patients. We should be open because there it can just go like a flu. So will all patients with high risk factors will need a basic evaluation with their counts, inflammatory markers like CRP, etc., and chest X-ray. If they don't have any of these features, we'll again see them after a period of 7 days, and after 14 days, we'll watch for the complication. Usually, this complication occurs in the second phase, that is the immune phase. So CKD or CKD and dialysis or transplant patients has to be very careful, especially if they have COVID positivity, even if they don't have any features of inflammation, high inflammatory markers. So definitely they need a regular follow-up, especially post-COVID period, because they can produce post-COVID pneumonia, then this thrombotic episode, because there can be multiple occlusion in the blood vessels. It can range from either brain, heart, blood, lower limb blood vessel. It can happen anywhere, because sometimes kidney may be functioning, the patient may be lying with a stroke. So it's a very sad state of affairs, especially any patients. So post-transplant also not spared. But interestingly, what we see is that a patient who underwent transplant after they have finished 6 months, the dose of immunosuppressive drugs are reduced. So they tend to have a better response, because usually we don't see the hyperimmune response which is seen in this immunologically active patient, and they tend to have lesser severity of infection, probably due to lesser dose of drugs. So, and probably this observation which is seen over last 1.5 years in the Calicut circle, what I've seen, and our experience regarding the high risk people, that is the dialysis people, because they will be coming to hospital every 2 days, weekly thrice, and spending 4 hours in the AC in the common pool. And for us, we in 75 patients, we lost almost 4 to 5 patients in the first wave. And with the vaccination, even though we do have more than 10 to 12 patients positivity, we lost only 1 patient. That is actually in that is the gravity of the good things that can be done with the vaccination. And it has been proved that with vaccination, the antibody response in CKD patients as well as transplant patients is delayed. And even though it is delayed, it will come. In dialysis patient, it will come at least 1 to 2 weeks later than the normal individual. But immunosuppressive patient, that is post-transplant, if you are putting the vaccine, the response is suboptimal. Still, suboptimal response also may be helpful in such a way that it may prevent pneumonia or some other thrombotic events. So whenever possible, we used to vaccinate all the patients. Before transplant, we'll wait for 2 weeks. If you are vaccinating that patient, second dose, we'll ask them to wait for 2 weeks for the transplant. If you are post-transplant, we used to vaccinate after 1 month. It's a mandatory vaccination, what we suggest, because it can really decrease the complication rates. And according to various studies all over the world, the mortality varies from 12 to 30%, because it depends upon the center to center, because especially tertiary or quaternary care centers, the patients coming with COVID will be severe COVID with acute kidney injury, multi-organ dysfunctions, superadded sepsis also. So the mortality person you can't judge, because higher centers will have a higher mortality because of the type of patients. And when the various studies, it has been shown that age more than 60, those with COPD, those with smoking, coronary artery disease, uncontrolled diabetes, those with acute kidney injury tend to have a higher mortality. That is a mortality study. And in the post-COVID scenario, the most common complication what we encounter was the post-COVID pneumonia. And what we see that if the patient had dyspnea, breathlessness, or they do have cough, if you are screening with a CT, you can easily diagnose early the COVID pneumonia, and early treatment with steroids tend to have a very good response, because chest X-ray usually we miss a lot of things. Even though the CT carries 100 times the radiation as X-ray, but in certain population, it is always better to screen with a CT if the patient is at least symptomatic. And next problem what we encounter is in post-COVID patients, those patients with diabetes without any renal dysfunction, they tend to have some sort of acute kidney injury during the COVID periods. These people tend to have most probably this pyelonephritis. Pyelonephritis in post-COVID scenario, almost we do have almost 10, 12 patients in last 1 year requiring dialysis with acute kidney injury requiring dialysis for post-COVID pyelonephritis. And this post-COVID pyelonephritis, interestingly, they tend to respond very late to therapy. Most probable reason is that they will be bombarded with steroids because of the other immunological effects. So the treatment-related side effects tend to come now. So if you are not treating with steroids, the patient will develop severe pneumonia and they go to ARDS, they go to ventilator, and they may die. And if you are treating with steroids, you tend to have complication related to the immunosuppression, because the uncontrolled diabetes can occur in COVID. Then steroid can cause immunosuppression. Then antifibrotic agents can produce slight immunosuppression. And finally, you tend to have immunosuppressed state with complicated infections. So now we are facing post-COVID 1 month, 1.5 months tend to have this AKIs due to the pyelonephritis. This is the most common pyelonephritis, the most common infection what we encounter. And you could see that it takes at least 3 weeks, 3 to 4 weeks parenteral therapy is required for patients to respond. Usually, all these pyelonephritis usually hardly need 7 to 10 days. And we usually will get a negative culture report because the patient will be on antibiotics from the hospital days. And they tend to develop this fungal, that is candida, white fungus, which causing urinary infection. And one patient, we do have a fungal ball on the kidney, and it has to be drained by CT guided aspiration. And luckily, all this AKI requiring dialysis due to the infection all survived. But COVID patient with COVID related acute kidney injury tend to have a higher mortality, more than 90%. COVID patient developing acute kidney injury during the initial phase carries a high mortality. But post-COVID, due to immunosuppression, suppose they are developing infection, pyelonephritis, AKI, they tend to have a better outcome. Okay, these are my observations since last 1.5 years, and especially this second wave, what we've seen in Calicut is that the chances of pyelonephritis is more. Probably it may be a selection bias because we tend to see only complicated cases being nephrologists. It will be treated by some other people. Only when the creatinine increases, we tend to see. Probably that's the reason. And we'll be seeing hardly few number of people because maybe because COVID is treated by, it has to be treated by many doctors. So the number of documented pyelonephritis may be very high, and probably some studies after 1 year, you may see that the post-COVID infections, the rates, it can be as high as 10 to 20%. And the only advice I would like to give all people is get your vaccination as early as possible and wear mask even if you are vaccinated, use sanitizer and keep a distance, do your routine work. Without doing your routine work, simply sitting at home, you can't do anything. So get vaccinated, use precautions and do your work. That is my request to all patients. But post-transplant patient, I tend to restrict them to their work. I ask them not to go to the public places, and usually all the what we usually tell to them during the first 6 months, to be extra cautious. And especially post-transplant patient, I used to extend that 6 months to at least 1 year, 1.5 years, for the sake of their safety. Okay, these are the last 1.5 years. And doctor's perspective, the important stress what we feel is that a lot of patients what we see on day-to-day basis lost due to the COVID, especially those with above 60 years with multiple comorbidities, cardiac issues, and previous history of stroke has been lost. And the our fellow workers, especially the dialysis technician, the stress they are undergoing while doing dialysis for the transplant patients, for the dialysis patients, ICU patients. It's a really very we have to appreciate the effort they are putting, because it is very difficult to even cannulate a difficult fistula under a foggy PP. So we have to congratulate them for their excellent effort. And the people who are putting their reasonably less effort is, I think, us, because we tend to have a relatively less contact time with these patients. So the nursing staff and the dialysis technician has to be appreciated at any cost during the care of these COVID patients, especially in nephrology. Okay.
Thank you very much, Dr. Vinu Gopal, for taking us through that journey. I'm going to start off with what is the current situation in Kerala right now, and when it comes to the wave, are there a lot of cases?
Yeah, Kerala, I think we do have a good documentation system, and today's cases are, I think, 13,350. I just had a message through my phone during the and the TPR is around 10 to 10.5%, and in Calicut it is around 13%. And in hospital, the number of cases are relatively low, because being a quaternary center, the patients who are coming to us with the slight complications are less. So I think more and more vaccination programs are going strongly, and we are getting less severe cases.
Doc, I don't think we've really spoken about this. Can you take us a little more detail into the journey post-COVID for a dialysis or a transplant patient? Because we hear people who had recovered from COVID having also not been able to make it through in life. And what are the possibilities?
Okay. Especially the complication what we see, especially a patient on dialysis, diagnosed to have COVID, and they have gone for a dialysis for 2 weeks, quarantine dialysis for 2 weeks, and one group doesn't have any complication. That patients usually tend to complain only regarding appetite. What we see that the weight has been reducing drastically due to the COVID-related decreased appetite and due to the increased inflammatory markers, even though there doesn't have any features of pneumonia or liver involvement, anything. All investigation will be fairly okay. But one thing is their appetite. It will take at least 4 to 6 weeks for them to improve the appetite. One point. Second is the hemoglobin drop. What we notice, because of I think there is a significant bone marrow suppression due to the COVID infection, and we tend to use high doses of erythropoietin, especially post-dialysis patients. And the other group who tend to develop this complication like pneumonia or pyelonephritis, they tend to lose weight more vigorously, and it took almost 3 to 4 months for them to recover to the pre-COVID time. So it's a really tough time for the dialysis patients to recover to their previous level. And the transplant patient, immediate, we don't have any experience with the immediate transplant patients. The earliest one was around 9 months. Then all other patients, what we got is after 7 to 8 years transplant patients. All the old patients, we stop mycophenolate temporarily. And actually, it's a blessing in disguise to change to azathioprine, because many of the people don't allow us to change the medication from MMF to azathioprine because they fear that rejection may occur. So we'll forcefully stop the MMF during the active COVID period. We'll investigate them. And actually, all the transplant patients, what I encounter, tend to respond, not respond. Actually, they did not have any complications because the number may be less. What I see, I hardly see around 18 post-transplant COVID positive patients in last 1 year. And most other patients are negative. I don't know whether they have developed an infection. They don't know, because the immunosuppression, the immunological reaction may not be there. So, and they tend to develop less severity of fever because of the immunosuppression. And these transplant patients, what I feel is that even though they are at a very high risk, they tend to have a very good course during this period. And most of the patients took their vaccination early in the period, because we tend to give that extra advantage for those patients with post-transplant because of the government guidelines. And what I feel is that post-transplant patients tend to behave very good after 6 months of transplant. Those patients post 6 months of renal transplant tend to behave very well. And post dialysis patients who develop symptomatic or COVID with complication, without complication, they tend to have decreased appetite for all patients. And it took almost 6 to 12 weeks them to recoup to their original routines.
So these are the general problems that you find in regular dialysis and post-transplant patients who have post-COVID effects, right, Doc?
Yeah.
Okay. Um, Doc, I'm going to go into a few queries.
Okay.
One question is post-transplant facing loose motion, whether
Hmm.
it is on because of COVID related or not COVID related. Is it okay to take ORS powder?
Yes, it depends on how your renal function is. First point, if renal function is normal, you can take ORS, no problem. Post-transplant diarrhea, usually the time of diarrhea is very important. Usually within the first 6 months, if it develops diarrhea, even though it may be due to drug-related or diet-related, you have always to rule out the CMV infection, because it's the most dangerous thing which presents as diarrhea. So always see your consultant, and probably they'll be doing the counts. If the counts are less, or the LFT showing abnormality and loose stools, it is unless otherwise proved it is CMV. So that's a very dangerous scenario, because we tend to see patients we'll give the CMV prophylaxis for 3 months. In the fourth one, they will be coming as loose stools. And they said that in 2 days it resolved. Probably it may wax and wane. So definitely patient has to seek the attention of a transplant physician and let them decide whether it is a simple diarrhea or it is due to the CMV.
Um, what is the CMV infection? Somebody just asked this question. Can you tell us a little more to
Okay. Okay. CMV means cytomegalovirus infection. It is a simple virus infection. If you are taking the entire people all over the world, we'll be infected with at least 87 to 90% of the patients, because here I can see in my screen 3 people, and of 2 will be having CMV at least, or otherwise all 3 will be having CMV positivity. Already we had just like a flu, we had a CMV infection. When your immunity is suppressed, this CMV will reactivate it. So in transplant patient, in first 3 months, you do have highest amount of immunosuppression, 3 to 6 months. So in 3 to 6 months, we tend to have this CMV coming up from inside our body. So to reduce this CMV related infection, we give this valganciclovir prophylaxis. So when the immunity is low, especially when immediate post-transplant or patient receiving an anti-rejection treatment, or patient recently had any other infection which reduces their total immunity, the cytomegalovirus infection can come. It can present like anything. It can present like diarrhea. It can present like decreased appetite. There can be increased serum creatinine. It can present as headache. It can present as neuropathy. It can mimic anything. So we always keep a DD of CMV in all the causes of post-transplant, especially in the immediate 6 months of transplant.
Thank you, Doc, for patiently explaining it in detail. Doc, the next question that we have is black fungus due to the high steroids?
Actually, black fungus infection, it is not due to high steroid, it is the immunosuppressive effect of our body. Because the COVID can cause immunosuppression and COVID related complications because we tend to use steroids, especially when there is an affection of the lungs. When there is a inflammatory response, or when it's suppose we tend to have an infection, our body tends to remove that infection by releasing so many things from our body, and these molecules directly go and attack or cause injury to our lungs, and then the lungs get swollen up. I'm telling in local language, it's swollen up. It's almost like the just like what I say. Uh, suppose suppose our lung is similar to the sponge. Okay, then if you are adding few glue to that, it will be stuck like that. It will be hard. So these molecules tend to make this lung hard. So in order to reduce that hardness, we are giving steroids because these molecules tend to decrease and lungs will be freed. So by doing that, our immunity will reduce. So already these black fungus, white fungus, everything can colonize in our body. If you are if you are not immunologically suppressed, definitely this will not cause any issue. Most of the patient, you can go through the literature, this COVID can injure the pancreas. So it can shoot up the sugars like anything. Certain people tends to come with sugars of thousands only due to COVID. So high sugars, immunosuppressed state, plus steroids, other comorbidities, and our age, all this helps to increase the chances of this black fungus.
Doc, you did mention, just out of curiosity, you did mention that patients who are uh, normal patients post-COVID have started the journey of CKD, right? In your experience, when they come in, do they have an acute failure? Do they have the chronic failure? Is it reversible? What has been your experience?
Actually, all cases of acute kidney injury, there is a chance from them to develop CKD. The chances are varies from 10% to 20%. So any patients with acute kidney injury has to be monitored for at least over a period of 3 months, then 6 months, then every year, because there will be because during an acute kidney injury there will be a loss of nephrons, kidney molecules. The rest of them will act extra work to do the maintain their normal work. So after a period of time, because during the period of acute kidney injury, the health of that person, the weight of that person may be only 60 kg. After a period of 10 years, it may be 80. So the extra work that has been done by this small number of nephrons, because suppose the creatinine tend to increase only when the kidney function falls below 50%. So suppose the patient is having only 70% function, still your function will be, creatinine will be normal. You feel that my kidney functions are normal. Suppose that patient gains a weight of 10 kg, they are eating high fat, high calorie, high protein diets, and junk foods, carbonated foods, etc. This add extra load to the existing kidney molecule. So they tend to develop this protein leak and develop chronic kidney injury, acute kidney injury changing into chronic kidney disease over a period of time. So it's a very slow process, but in a large population over a period of time, you are seeing many of the studies show that the CKDU, that is chronic kidney disease of unknown origin. This unknown may be some part of this AKI not followed up by doctor, patient, or anybody, because we tend to feel that AKI is fully reversible. To an extent, it is a progressive disease.
Thank you, Doc. Um, a little not so COVID related, to take a break from the COVID. There's somebody who's asking that I am 9 years post transplant. Can I have aloe vera, tulsi, like every day? Well,
Sorry?
somebody who's here post transplant, 9 years
Uh,
post transplant,
uh.
the person wants to know, can they have leaves like aloe vera, tulsi, and those leaves? Is it okay for a post transplant to consume such things?
Yeah, no problem. Just like normal people.
Okay.
Okay.
Um,
Only thing is that which increases the absorption of the tacrolimus is grape juice. Grape juice.
okay.
If you're taking, case reports has been seen that if you're taking grape juice along with your tacrolimus, this grape juice tend to inhibit the metabolizing enzyme of the tacrolimus, and suddenly your tac level can go up.
Okay.
Grape juice.
Thank you, Doc. Our next question over here is on BMI. This is
Hmm.
important for a kidney transplant. Why is it so important for the surgery as well? Is this BMI most important for the recipient only or for the donor also?
Actually, BMI is important for all of us, not for kidney disease, including me, you, everybody should be aware of the BMI. Because Asian standards, the BMI, it should be less than 23.5, but we tend to increase it to 25 because for our convenience. Eh? Because it is very difficult to get below 23.5. Especially those who are not that much dedicated to their routine activities. So one is, suppose a donor comes with an obesity, that is, we tend to give more preference to the donor. Actually, if the BMI is more than 35, we won't consider donor. And from 30 to 35, we ask them there is a higher risk for developing chronic kidney disease if you are donating your kidney at this weight. If you can reduce your weight, it is well and good. That's a fun point. And then transplant patients, we tend to ask them, that is an important paradox because all the disease in literature tend to have tend to go along with the obesity, because if you do have high BMI, tend to have high mortality. But only condition which carries a better prognosis for higher BMI is those who are undergoing dialysis, and they tend to have a higher survival compared to lean people, probably due to the nutritional effects and the cost we don't know. For the transplant patient, we ask them to reduce BMI to less than 30. And if the BMI is more than 40, the benefit of doing transplant over dialysis is lost. So if the patient is having a BMI more than 40, we ask them that there is no need to go for a transplant because the advantage of transplant and survival is less if if you're undergoing transplant with a BMI more than 40. So next is the confusion when the patient is having a BMI around between 30 and 35. Then we have to ask them to reduce the BMI like less than 30. And very importantly, above 30 people has to be screened vigorously for their coronaries, because it's a live, especially in live donation, one person is sacrificing their kidney, the other patient should have a proper benefit, and patient having complication with the functioning kidney is very sad. So above 30, we have to counsel like the main thing. Always ask them to reduce the weight before transplant, because post transplant weight reduction is almost impossible.
Why is that, Doc, post transplant? That's the first time I'm hearing that.
Post transplant, okay, post transplant, the weight loss is difficult. What I mean is that it has to be highly motivated people, because one is you having drugs, because all of the dialysis patients, if you are go through them, they are malnourished, especially because they don't have good quality of protein intake. Because if you are taking a good quality of protein intake, diet, etc., with a good quality of dialysis, the cost is really to maintain that phase is quite high. So definitely they tend to have most of the people will be malnourished with a BMI less than 25 or 23. If you are checking this group of people, when they undergo post-transplant, suddenly their uremic milieu is gone, and suddenly they tend to have a very good appetite after a long period. Many of the patients, as all to delay the start of dialysis, they tend to say that I don't have any GI symptoms, I don't have nausea, I don't have vomiting, because if the creatinine is 10 and they have these symptoms, doctor will ask them to dialyze. So they will say there is no problem, there is no vomiting, and they will be losing all the weight. And post-transplant, when the uremic milieu goes, suddenly patient starts eating, and steroid will have a slight effect, because steroids, hardly we tend to give 5 milligram steroid post after 3 months. So we can't blame on steroids after 3 months. Then by 3 months, probably the patients has enjoyed the luxury of eating more, and it's up to their determination whether they will be able to keep the BMI below 25.
Somebody's asking us that I am post-COVID. I'm a post-transplant patient. Is it okay to take Giloy?
What is that?
Giloy.
What is
It's a plant. I think it's normally used for increasing immunity. It's like a
I don't know. Sorry, I don't know. I don't know the content, so I won't tell.
Okay. Our next question is post-transplant. I have high albumin slash creatine ratio 19 and 5. My creatine is normal. What should I do to bring down the ratio?
Okay, the ratio post-transplant protein, that is simple words, post-transplant proteinuria with normal graft function. This is the diagnosis. So then you have to go back to your primary disease. Suppose your primary disease is a protein leaking disease, it tends to develop in the new kidney. One point. Second point is there are a lot of new proteinuria kidney lesion that can develop in these kidneys. So first and foremost is if protein creatine ratio is 19.4, means the leaking of protein is quite high. It is as high as 19,000, with normal is 150. So they have to do an ultrasound and undergo a renal biopsy, and what are the changes. And the previous biopsy, like the pre-transplant kidney disease biopsy, also has to be cross-checked. So then only we can decide what all things to be done. It can be recurrent FSGS or de novo FSGS, depending upon the biopsy results, we can proceed.
Okay, doc. Thank you.
Mm-hmm.
Very interesting question. Something that I was also very curious about. Is there any increase in emotional sensitivity in the course of time? Like have you noticed this in a transplant patient? 1 year post transplant, 2 years post transplant, difference 10 years post transplant or 30 years post transplant. Is there any research to prove the change
What
in
is emotional? What is the emotional sensitivity?
emotional sensitivity? Is like, for example, I know a lot of patients who can actually, because of steroid induced, when they watch a movie, cry.
Sorry, they
Emotional sensitivity, they can cry very fast. They feel low.
emotional lability. Okay,
Yeah.
emotional lability.
Yeah, so they cry fast. I mean, I've noticed this in post transplant. When they cry, they say, okay, I'm not crying, it's just my steroids.
Actually, most of the patient, if you are looking, I don't know the data, but as a medical person, what I see is that most of the patients, if you go by literature, around 80 to 88% of the patients who undergo transplantation suffers from depression or some other mood disorders or etc. All these things are slightly treated during that period, and post-transplant, many of the things are not monitored or taken care of. And only most important thing they will be looking for is protein leak or creatinine. That is the only thing they will be looking. So we doctors tend to look at that perspective also. So there is a issue with ourselves also. So definitely a multidisciplinary team for these people, pre-transplant, post-transplant, this psychiatric reevaluation will help them a lot, because many of the people may not be that stable, mentally stable, pre-transplant also, and this problem will persist even after transplant. So it will not be addressed. Probably that's the main reason.
I think just the awareness of having this emotional issues post transplant itself is a good way to kind of be aware of it, and yeah.
Definitely. If they're feeling that, if they're feeling that, we do have in our transplant program, always we tend to ask them to review to the psychiatrist after 1 month, then 3 months, then 6 months. Just want to see the psychiatrist how they know, because they will be assessing pre-transplant and post-transplant, six months. There are certain people who are still taking the medicines, and they are reducing the medicine over a period of 3 to 6 months.
I think this is one aspect, Doc. I'm a caregiver for the last 10 years for my husband. I think this is one aspect that is never spoken about in the journey of CKD. At least not that much of having and taking care of the mental and the emotional issues. Having a psychiatrist on board, I think people are not even aware of it. Like
That
when
is mandatory, because for all transplant, we have to get a psychiatric opinion. What we do is that in a transplant, in our dialysis unit, we tend to show those people who are willing to see a psychiatrist. We ask them to show, because many of the decreased appetite, tiredness, decreased sleep, everything can be due to the depression. Because no patients will be very happy coming to hospital and spending a lot of money and doing dialysis. Definitely. So uh, many of people, you can see dramatic difference after seeing the psychiatrist. What I'm telling is because my wife is a psychiatrist who is working in medical college. That's the reason why I'm more inclined to this angle.
I completely agree with you, Doc. I mean, I that's one of the things that I also talk about, having a psychiatrist or a psychologist on board to kind of be more aware of what
Now
you.
the people are ready to see the doctors. Only problem is that we consultant should offer them.
Yeah.
Suppose we offer them that you have to see certain person, they will help you to tackle your issues. Most of the people will go. Only very few people, especially only very few people will be reluctant to go. Majority of the cases, what happens is that we don't tell. We'll give pantoprazole, we'll give Lomstal, etc. Maybe it is due to the depression. Pantoprazole will not resolve depression. So that's a uncared, unseen area in our population.
Thank you very much, Doc, for actually bringing that point. I'm sure it's going to be really helpful coming from a doctor to the patient community of how to handle mental diseases through awareness. That's going to make a huge difference to the whole journey of CKD. Our next question that we have here, I am an IgA nephropathy patient. My creatinine is 1.4 mg. My doctor stopped my pregnenolone medication as my protein spill became normal. But now I notice my blood pressure is rising and my BP tablet is unable to control it. Is this normal when steroids are stopped?
Actually, in IgA nephropathy, the indication for giving steroids is the presence of protein leak more than 1 gram, which is not treated by protein medication like telmisartan, olmesartan, etc. And in biopsy, we tend to have high proliferatory index, then definitely we'll go for steroids. And the role of steroid is only for up to 6 months. We don't give steroids more than 6 months. Definitely, uh, one reason for uncontrolled hypertension may be the diet, maybe high salt diet. The patient have developed obesity, which can also cause resistance to antihypertensives. Because if you're taking a pinch of salt, if you are taking 1 gram salt extra per day, you have to increase the drug by at least one drug. If you are taking 3 grams extra salt, you have to add three drugs. That is the way at which you have to increase the antihypertensive in any patients. So the sensitivity of antihypertensives reduces significantly with your diet, especially salt diet. Because and another important thing is the role of steroid is hardly for 6 months. So the after 6 months we tend to treat it with only this AC inhibitors, statins, and the vitamin D, etc. That is the only way you can go. And antihypertensive, you can have 6 or 7 groups. What first you have to check whether you are taking a decent quality medicine, whether you are taking properly. Your diet should be monitored. If everything is right and your BP is not controlled, you have to increase the antihypertensives. And don't compare with any other IgA with your IgA, because every case of IgA, every case is different.
Thank you once again, Doc. Our next question is on the tacrolimus levels. Why does tacrolimus levels increase in spite of low dose of medicines in just a short span of time, in just 4 to 5 months post-transplant? They've added to say, I have switched to 0.7 mg now. Some of the things that the patient wants to ask is, have I overlooked something? Is tachograph needs to be changed immediately as TAC levels are shooting high to 22 is to between 22 24 range? Any changes to be done in terms of the timing to have it or post food, or should I maintain a certain gap? Does any of these impact my TAC levels?
Okay, TAC is the most commonly monitored drug post-transplant, because we don't monitor other drug values post-transplant. TAC tends to vary quite a lot in many patients. And what we do is that we also see this sudden increase or decrease in TAC level. We tend to do in last 2 years, we tend to do the tacrolimus gene assay. Then we'll send that sample to TAC. I think in Chennai, they are doing tacrolimus gene assay, because this tacrolimus is metabolized by certain enzymes in liver as well as small intestine. And this enzyme, for certain people, it's a highly fastly metabolizing enzyme. That means if you are giving tacrolimus, suddenly, hardly you get few tacrolimus to your body. So those patients need to have a higher dose of tacrolimus. And those with the intermediate metabolizer than poor metabolizer. For poor metabolizer, we hardly require few doses of drugs. Then another problem is that the absorption. If you are taking food 1 hour prior and within 1 hour pre and post tacrolimus intake, tends to decrease the uptake of tacrolimus. So this also makes a difference, especially post-transplant. After a period of time, if your kidney functions are stable, majority of the patient will not be checking the tacrolimus. This 1 hour gap may not be there. Another problem, high fatty foods can decrease the absorption of tacrolimus if you're taking within that 1 hour. Another thing is that commonly used drugs. Commonly used drugs that can increase the tacrolimus level is one is erythromycin, clarithromycin, which can be prescribed from dermatologists to pulmonologists, general medicine. Everybody can have a upper respiratory infection. You may be taking erythromycin. It can inhibit this enzyme. Suddenly, TAC level can jump up. Then infections, fungal infections. And these fungal infection drugs like ketoconazole, fluconazole, everything can increase tacrolimus. So to an extent, then the drug like antihypertensive like diltiazem, verapamil, Nicardia, this is commonly used drugs post-transplant hypertensive patients tend to have an increase in tacrolimus. Then change in brand and change in certain batches of medicine also tend to have these levels. So we go by patient symptom as well as creatinine values. If there is a change in creatinine value, usually we tend to check attack level every week post-transplant for first 3 months. Then we tend to reduce the frequency. Then recently we found that many of the people tend to have a very low tacrolimus. That is, most of their level was 7. Then suddenly everybody was changing to 4, and with no reasons it is going up again. And no food change, no drug added, certain things we don't know still. So if the TAC level is above 10, definitely you have to reduce the dose. The first 3 months, we tend to keep it around 7 to 10, even though the international guideline says like that we tend to keep at a relatively lower rate. Because for a live related transplant, usually the donor will be, our patients usually will be having 50 to 60 years donor, older donor. So older kidney may not tolerate high TAC level. So we tend to keep around 7 to 8 immediate post-transplant. After 3 months, we tend to keep around 4 to 6. That's our standards, what we keep. And the MMF also, we tend to give only 1.5 gram post-transplant. And after 1 month, we tend to reduce to 1 gram only.
Thank you, Doc. I've got a very interesting question coming in. I see a lot of men getting worried with this question actually. What can be done to avoid hair loss episode after COVID? As we're already on steroid, which causes hair loss.
I don't know. Sorry.
Any answers for that question?
I think maybe nutritional deficiency may play a part, because any illness, it is not COVID, any viral infections, any stressful events can have hair loss. So that will be that will come again after, just like pregnancy and viral infection, dengue, anything, it can cause a significant hair loss, and it will come back again after that stress. But those with immunosuppression related alopecia like tacrolimus can cause significant hair loss. And I don't know whether there is any treatment for that, because we can't stop tacrolimus. And the biotin, etc., can be given for this hair loss. It's a nutritional supplementation, and protein diet somehow can help. I think that's just like any other infection.
Someone wants to know that post-transplant, is it good to do yoga?
I can do yoga. I don't know whether it is beneficial, if it reduces the stress. The medical aspects of yoga, maybe it's a maybe it gives us a relaxation. It reduces the hypertension. It reduces the stress. So it may be helpful. And only thing that you have to ask your surgeon regarding your scar, there's a chance of hernia. So which all position should be avoided, etc.
Doc, one of the discussions that we never ever spoke about too much in the past was the homocysteine levels. Homocysteine levels?
Homocysteine, you mean homocysteine?
Homocysteine levels, sorry, yes. Sorry, the homocysteine levels is not a topic discussed post-transplant too much in any of our discussions with doctors. And personally, I experienced my husband's levels being at 15.8, which is a mild increase. And he had an aortic dissection, had 2 open heart surgeries. And he experienced a few symptoms like dizziness, a little bit of blackouts. They doubted vertigo for the same, tingling in the right finger. Do you have any of your viewpoints on this topic?
Actually, homocysteine. Only what I know about homocysteine is it will cause vascular thrombosis. Whenever there is a occlusion of the vessels, hyperhomocystinemia is a cause. And for that, you can give this folic acid. And it can cause obstruction to all vessels, like heart vessels, brain vessels, etc. And post-transplant hyperhomocysteemia, I don't have any. I've not thought about that. I will have a read and get back to you.
Okay. Yes, Doc. I'll get back to you on that. And somebody is asking 15 kgs weight gain in 5 months post-transplant. What is the advice you'd have to give to that patient?
What is their original weight, their height, their BMI? These things should be there. So if their BMI was 18 and now it is 23.5, nothing has to be done. Yeah. Ask them to maintain this weight.
Okay.
If the BMI is high, definitely they have to bring down the weight by reducing the food. They have to walk. I used to ask the patients from 2 weeks onwards, after the removal of drain, ask them to walk for at least 3 kilometers per day for first month. Then most of the people will be walking for at least 5 kilometers with donor. They have to go with the donor, especially if they are their wife or brother or sister. They have to bring them and they have to walk for at least 5 kilometers, because post-transplant in donors, we tend to see that they become obese they develop dyslipidemia, nobody will take care of them. And this donor will be bringing the patient, and the patient will be, you'll be doing all investigations to the recipient. And the donor will not know what is happening to their body. So donor has to be extra cautious, especially.
They just replied back from 50. I moved to 65. But again, we're gonna ask the height ratio because that's how we
BMI.
calculate the BMI. But 65 doesn't seem to be a bad weight overall. Even if you're 5.4, maybe a
A
few.
point for that.
Yeah, yeah. So yeah, it depends on the weight. Um, just being weight conscious, I know a little bit information on that. So I've added my own little masala to that. Doc, you did mention about the donor putting on weight post donation, right? I'm
I
very
think, okay, uh, because suppose you are removing one kidney, and the one kidney will be doing all other work. Suppose you are increasing your weight, then there is a terminology called hyperfiltration, because for the excess weight, that kidney has to function. So there is a chance for protein leak. If they are gaining again weight, this protein leak will worsen. And finally, when they develops a pedal edema or a swelling of leg, they will come. Then you will see urine albumin 2 plus. Then you'll be very sad to see, because it will progress. So they have to reduce their weight to the respected BMI. So we advise them to maintain a BMI less than 25. Then only we'll proceed with transplant.
okay. Very interesting question that actually created a ruckus in the last 1 year in the CKD community itself. And this is a discussion about vaccines. And in fact, we had an entire discussion on the vaccine with some senior nephrologists. And somebody's asked a question based on that. Can tetanus, anti-rabies vaccines, all that be given post-transplant?
The criteria for giving vaccination post-transplant is published all over the world. Only vaccine that can not be given is live vaccines. All other vaccines can be given. Like live vaccines, example, commonly used live vaccines are chickenpox. That is the reason why we are giving prior to transplant, we'll give 2 doses of chickenpox vaccine, so that the risk of developing chickenpox post-transplant and complication can be reduced. Second is typhoid oral vaccines. I don't know whether it is available now. It was available previously. We used to take. So now oral typhoid vaccine. Then is a vaccine which is given to kids are rotavirus. It is a live virus. So then another is the polio. Then another is MMR. These all vaccine cannot be given to these patients. And all vaccines, there is a chance. Even the COVID vaccine, there is a case report from US stating that post-transplant COVID vaccination has incited a rejection episode. Theoretically, it can produce, because definitely it is improving our immunity against certain, because we can't say that only to COVID-19 our cells should react. So there will be some sort of reaction taking place in our body, and rarely you can get. But compared to the mortality given by the COVID, it is very minimal. So I always go for all types of vaccination in post-transplant patients.
Yes, yes, Doc. I think we have come to the end of our episode, and I think it was a wonderful experience actually getting you to um, answer so many questions so patiently and giving us a very different insight in many ways. Doc, to end the session, I'm going to ask you, since they talk about people in India moving towards the third wave currently, a small bit of advice to the CKD community in terms of do's, don'ts, which could be regular, but at the same time, also mentally and emotionally, how they have to be ready. Because I think the second wave kind of created ruckus, a little more extra for the CKD community because of what they deal with and the constant visits to the hospital. Can you give us a little more? Can you give them a little?
Yeah. Actually, for first wave, second wave, third wave, fourth wave, fifth wave, always only few advices. Vaccinate at the earliest. Vaccinate your relatives. Vaccinate your caregivers. First point. Then wear mask. Your caregivers, everybody should wear mask. Avoid unnecessary visit to your relatives and avoid unnecessary visit to your house. Even if somebody is coming to your house, wear mask. Then you can talk. Masks are not that costly now. If you're comparing the stay at home, stay at hospital with ventilator, the cost of mask is very minimal. So you have to use your mask, then sanitize, then vaccinate. These are the only things you can do, and avoid dining out or going to high crowd areas. That's the only thing you can tell.
Thank you very much, Doctor. And well, on behalf of the rest of us from the CKD community, we'd like to take the opportunity to thank Biocon for joining with the Kidney Warrior Foundation to create this wonderful awareness on the journey of CKD with the whole sheer aim of making the lives of CKD more easier, more simpler, and breaking it down. And for lovely doctors like you, Dr. Vinu Gopal, for joining us and sharing your time with us, with the community, it means a lot. So on behalf of Biocon and Kidney Warrior Foundation, I'd like to say thank you very much for joining us, and we hope to meet you again on another forum.
Okay, thank you.